for joining us. My name is Maureen, and I am the current president of City Club. Our mission is to inform, engage, and connect our community to strengthen the civic health of our region. We emphasize civil conversations and listening to others. I haven't brought it up in a while, but we also aim to add light, not heat, to issues of local importance. Next month, we're delighted to welcome James Fallows back to City Club. In addition to being a prolific author, James Fallows has been a correspondent for The Atlantic for nearly 40 years. His presentation is The Future of Our Democracy. Many of you will remember when James and his wife Deb were here to talk about the travels that informed their book, Our Towns, a 100,000-mile journey into the heart of America. I'd like to thank the volunteers who are making our program possible today. I'd like to thank Robert Clark of KMRE Radio, who's recording today's program, as well as BTV10, who will be showing it to their viewers. If you know of others who would have liked to have joined us today and who weren't able, please direct them to the City Club website. This program should be there next week. As always, I'd also like to thank our business sponsors. They are Western Washington University, Whatcom Community College, Whatcom Community Foundation, Village Books, Unity Care Northwest, Pacific Continental Realty, the Opportunity Council, Danny Neal of the Mulyot Group, Lummi Commercial Company, and Larson Gross. Finally, we know you will have questions today, and we hope to answer as many of them as possible. And now I'd like to turn things over to Heather Erb, who will introduce our speakers and moderate today's program.
Thank you, Maureen. Today's program is entitled Everything You Wanted to Know About the COVID-19 Vaccines and Their Rollout. Our presenters for today's program are SheAnne Allen and Kathy Bay. SheAnne Allen is the COVID-19 Vaccine Director and the Deputy Prevention and Community Health Response Director at the Washington State Department of Health. SheAnne received her master's in public health from the University of Washington in 2013 and her bachelor's from the University of Wisconsin. SheAnne has been with the department for 15 years. A large portion of her career was spent in tuberculosis in a variety of roles. Kathy Bay is the Quality Epidemiology and School Section Manager of the Office of Immunizations and Child Profile at the Washington State Department of Health. She has been a nurse for 34 years, obtaining her BSN from the University of Tennessee, a master's in nursing from the University of Washington, and a doctorate of nursing practice from the University of San Francisco. Kathy served in the United States Navy Nurse Corps for 20 years in locations both in the United States and overseas. Also in attendance today is Hannah Fabash from Department of Health to help with answering audience questions. SheAnne and Kathy, welcome, and I will turn this program over to you.
Thank you so much. So for right now, I think it is actually just me, and I am Kathy. SheAnne's going to follow me in the presentation, and if we could put the slides up, I'd appreciate it. So you could just go ahead and go to the third slide. So I wanted to start with a little bit of an overview to talk about vaccines, talking a little bit about safety and efficacy of vaccines, because those two things are really critical for the idea of having vaccines and being able to ensure that we can utilize them effectively. So all vaccines have sort of stages. What I usually hear from folks as I do presentations in advance is, well, how do we know that the vaccine is safe? And we've done this so quickly. And, this time last year, we were still identifying this, novel virus, as we kept calling it last year at this time. And how do we know that we could get a vaccine so quickly? And so the things that I'd like to ensure that people are aware of are that vaccine safety is a critical part of the process, but there are clinical trials and things that happen from the idea of the development of the vaccine to its actual use in individuals. And so there's the preclinical trial states that you can see kind of in the first groove with the 3 steps that are in there. And then there's the clinical trials that are part of the phases, the 3 phases. And I know everyone's hearing right now about the Johnson & Johnson has finished its phase 3 clinical trial. and they're going to have their review process happening on Friday with the FDA as part of the FDA's review committee. And then this weekend, ACIP is going to look at the same information. So the clinical trial sizes depend on, again, the urgency of the process and the supports that are available for the organization. So in consideration of the 2 vaccines that we currently have available, as well as those that are coming, both of our current vaccines had really, really large phase 3 clinical trials. And so it makes a huge difference in the idea of, again, the number of people that were involved in the clinical trial and the investigation process. Next slide. So the pathway for us for licensure or approval for use is really established based on standards for ensuring safety. So a couple of things that happen as an automatic process is after the clinical trials are completed, this company has to ask for permission from the FDA to actually license or to allow for emergency use authorization, or again, in general circumstances, expanded access. With both of the vaccines that we have right now, they are both available under emergency use authorization because the US is still in the middle of a pandemic. We did not celebrate, but we were sorry from a United States standpoint earlier this week with knowing that over 500,000 people in the US have died. So how can we continue to move forward with vaccinations as a way to be able to help prevent vaccine preventable diseases? So the FDA approval happens. There's actually a review committee that is an advisory group that recommends to FDA whether they should approve vaccines or not. It's a group of clinical professionals and scientists, so physicians and leaders in healthcare that actually review all of the clinical evidence from the trials and define if they feel like that vaccine is safe and if it has efficacy, if it'll work to be able to do what we think it needs to do. And then they give a recommendation to the FDA for licensure or emergency use in this case. And so for both of the 2 vaccines we currently have, Pfizer and Moderna, both of them went through that process and were granted emergency use authorization. The next step to that is then it goes to CDC. And the CDC has also an advisory committee called ACIP, or the Advisory Committee on Immunization Practices. And that group is also made up of a group of physicians and nurse practitioners, and scientists and leaders who look at the process again of how the clinical trials happen, the outcomes from the clinical trials, and then they give a recommendation that if it is approved or it's able to be utilized, what populations would the vaccine benefit? And so they use the clinical trial outcomes to make decisions on that, and then they give that recommendation to CDC. So for both of the vaccines that we currently have, they both went through the FDA approval process, through the AIC approval process, and then Washington actually had 1/3 step that happened as one of the states that did an additional review process. And so in late last year, I think Kathy Lofi, who was our current health officer at that time, talked about how important the safety of the vaccines was to her and to the Department of Health and to the state leaders. And so we actually joined a Western Pacific group that includes clinical leaders from Washington, California, Oregon, and Nevada, who actually did a 3rd review of the literature, 3rd review of all the clinical trial information, and gave recommendations. And the 2 physicians from Washington that were involved in the review both talked publicly in a press conference and then additionally in other meetings and presentations about not only did they think that it was important for individuals to be vaccinated with the vaccines, they felt they were safe and effective, but that both of them would be vaccinated. Next slide. In thinking a little bit about the vaccine process, again, there are well over 200,000 or 200 vaccines that are kind of in testing phases right now in the world. Many of them are being tested in other countries. In the US, there are several clinical trials that are in process right now. And I usually like to tell people about places that they can go for additional information. And one of the things I think is pretty cool is, again, this is actually public information, as are the 2 meetings that I talked about. Anyone can watch the ACIP meeting and look at the slides, and anyone can watch the FDA review committee process and look at their information that was publicly released this morning as far as their plans for their meeting later this week. So I do encourage you, if you have questions or concerns about it, that you look to those resources as trusted sources from a scientific and evidence standpoint. Next slide. So I've referred to two vaccines recently, and I wanted to give a little bit of an update. Currently, there are two. There's the Pfizer-BioNTech vaccine. It's actually a 2-dose vaccine, and it is an mRNA vaccine. You get the initial dose, and then 21 days or 3 weeks later, you get a booster dose. The initial and the booster dose are exactly the same medication. We usually will break up the way that the shipments arrive, and they are dispersed out is as primary or booster doses. So sometimes we've asked providers to ensure that people are getting their second dose, and if possible, to get that dose done, to get that appointment scheduled when they come in for their first one. So many providers will run, booster dose clinics. Again, same medication each time. The other vaccine that is an mRNA vaccine is the Moderna vaccine, and that also requires 2 doses. And the second dose for that one is 28 days after the first. I know on some of the questions that I saw, some of the questions were, how quickly can you get the medication? So CDC says that, you can get a vaccine 4 days early. So for the Pfizer vaccine, you can get it as low as 17 days after the first dose, and for the Moderna vaccine at 24 days. But they do recommend that you stay as close as possible to that recommended period, so the 21 or 28 days, depending on the vaccine. There is research that shows, there's clinical evidence that shows that up to 6 weeks or 42 days after the initial dose that the vaccines are still effective. But again, our goal is to continue to ensure that people are vaccinated and that we're staying as close to that timeline as we can. Because that's what the clinical trial showed was the most effective. There are other vaccines that are currently in phase 3 clinical trials in the US, and I just added a couple of them because they're the ones that everyone you'll hear talked about in the US a lot. Again, the Johnson & Johnson vaccine, and the company that kind of manages their vaccine arm in Johnson & Johnson is Janssen. And it is a single dose vaccine. And it's a different type of vaccine. It's called a viral vector vaccine, and it's just the way that the vaccines work. I don't know that we have time to talk about that today overall, but I'm happy to provide some information if there's a goal for folks to hear more about that. The other vaccine that you've probably heard quite a bit about is the AstraZeneca vaccine, and that's because that vaccine was actually developed in Oxford, had some US partners involved, and it is very well in use in the United Kingdom and in Europe and other countries. So those vaccines, both the Johnson & Johnson and the AstraZeneca vaccine, are both, again, J&J is having their hearing on Friday, and then we'll wait and see what they come from the FDA meeting, and then ongoing planning for that. And AstraZeneca, I anticipate, what I've heard is that they will be asking for emergency use authorization at some point in March or April, probably, with the idea that it would be available after that for use. So one of the things to think about with the vaccine effectiveness, I'm good either way. One of the things to think about with the vaccine effectiveness, again, is, how good is it, or how does it work? And the Pfizer and BioNTech, Pfizer, BioNTech, and the Moderna vaccine, both of them have what we call 95% effectiveness. That was against the initial strain, or without additional mutations of the COVID virus. But we anticipate, based on the science that we're looking at, that the vaccines are both still very effective against other strains, including the South African and the UK strain, as well as some others. Viruses mutate. That's one of the challenges we have with the influenza, is every year we have a new vaccine. And we don't know what the impact is going to be of the vaccines in the future with, will it need to be an annual vaccination? We have to get it more than once. How will that work? And until we have more information about that, right now, we're still in that pattern of we just need to continue to move to get people vaccinated. But for both the Pfizer and BioNTech, again, they've both defined themselves as being effective against the initial strains as well as the mutations that we found. The virus, when it enters your body and you have whatever you have for immune system response, and then other viruses that might be circulating in your body at the same time, when you expose someone else, and you transition the virus out of your body because you've killed it inside your body, the challenge is that virus has evolved or mutated a little bit. So mutations continue to occur. That's why it's so important that we continue all the right steps around social distancing and masking and doing the other things like hand hygiene that are important. Next slide. So thinking about, the idea of vaccine safety, I really love to make sure that folks know about the VAERS system. It is the US's early warning system. It's been in place for a long time, more than 40 years now, or almost 40 years now, and really is part of the process that's utilized. The thing that I think is wonderful is that anyone can report to VAERS. VAERS is a system that you can utilize the CDC's website or the HHS website and be able to go in and enter information. If you got your vaccine and you have what you feel like is a problem after you were vaccinated, you can report it to the system. The fact that it's a US-wide database means that there's so much power in the number of people that are reporting any kind of events that it's easier for us to identify if there is something that happens with a few people, but not necessarily many. So the power in the statistics of a lot of people entering information helps. In addition to that idea, it is a public reporting system. You can actually look at the information about what's been reported with relation to the VAERS system with vaccines, any vaccine, including the COVID vaccine. The thing you have to be careful about is it is a reporting system, and just because there's it's sort of a time-related connection to the vaccine does not mean that the vaccine actually caused the event. So I could say I got my vaccine today, and tomorrow I'm in a car accident. I could say that the vaccine caused the car accident, when really maybe my foot slid off the brake as I was driving, or something distracted me, or there was another issue. I could still report to VAERS and say that that the vaccine caused the event. So it's not a causal relationship, but it's a temporal or time-based relationship. So important for you to consider that if you are looking at VAERS data. Next slide. So there are a lot of different safety systems that are in place for vaccines, some of them specifically created this year for the COVID virus vaccine, and then others that have been in place for a number of years. You can see the VAERS system is second on the list. I'm going to talk about one other in specific because it's a Washington Foundation program, but I think it's important that people know that there are both active and surveillance systems as well as passive processes that are used. There's also the ability of clinicians, healthcare workers that are providing vaccines to ask for support to be able to investigate a scenario so that they can ensure that they're providing the best care for a patient who maybe is having a complication after they were vaccinated. And so there are resources for that as well. And all of those are on the CDC website, but at the Department of Health, we can also help you with that. And so the next thing, you could just go to the next slide. The one I want to talk about that I think is really interesting is the vaccine safety data link. And the reason that I love to talk about it is that it's part of a Washington program. So around the United States, there are 9 participating integrated healthcare organizations with data for over 12 million people per year. So what happens is, and Kaiser is the place in Washington, you can see where the other locations are in the US. So because the power of, again, looking at the data to do comparison. I talked about the car accident, maybe that, I got vaccinated and then I had a car accident. And they could actually go back and go, wow, how many people in the US have car accidents every day? And so looking at that data and looking at it in foundation helps to be able to do some determination is if there are clinical issues or concerns that are smaller that weren't picked up in clinical trials, this vaccine safety data link actually gives us really good information to be able to look at comparison numbers for how many people actually still have, whether it's a car accident or a stroke or a heart attack, or other information in comparison to those that were vaccinated. So that's really important to think about because we know that events still continue to occur to people. And so being able to balance that information and know is really important. Next slide. One of the programs that's brand new this year as part of the COVID vaccine work is the VSafe program. And VSafe is just, it really is an after vaccination health checker. And so the cool thing about it is when you go get your vaccine, wherever you get it, and my hope is that they'll have information posted or you can ask about it. They might give you a little flyer that talks about it. It's a little barcode scanner or UBC code that you can scan with your phone. You can also go directly to the CDC website and enroll in the VSafe program. And what happens is you get a text message from this automated system for the first week after you're vaccinated, and then weekly for a month, and then at the 1 month, at the 3 month, and at the 6 months, and then again at 12. So the cool thing is that you can disenroll in the program at any time or unsubscribe, but it does a little check to ask you how you're feeling, ask you about your symptoms, and goes through sort of a check process with you to see what kinds of symptoms you're having. Like I said, the vaccines that we have had, they've finished their clinical trials, but they're still fairly new for us for use. And so continuing to gather information will help us to be able to make some decisions about, maybe the information that's being collected as part of our safety trial helps us impact that idea of, how frequently the vaccine needs to be given, or ongoing evaluation of the information will help with that. So again, everyone can enroll in VSafe. I do encourage folks to do that. And if you do have something that you report on the VSafe system through that automated that requires someone to call you because it has a significance enough event, then they will actually do a VAERS report for you. The VAERS reporting is required of all providers that are involved, but specifically, you may not tell your provider that you had something happen after you were vaccinated. So the VSafe system is another way to be able to capture that information. Next slide. So I wanted to talk a little bit to give you a little detail on what people are reporting in VSafe. And again, this information is actually from one of those presentations that was done. This came from the ACIP, or the Advisory Committee on Immunization Practices meeting that happened in January. It's posted on the CDC website. This is information that was from that period of time. You can see this is data through the 24th of January that CDC presented to the ACIP meeting. Again, the idea of vaccine safety doesn't stop when that first approval happened, but continues on through the processes of vaccine use and ongoing. And so data that was reported to VSafe was based on, again, which vaccine was it, the Pfizer or the BioNTech or the Moderna vaccine, and then kind of a combination of the two together. At this point in time, they'd had over 21 million, almost 22 million people who have been vaccinated. And then looking at the number of people who participated, it's just shy of 10% of the folks that got vaccinated participated in the VSafe program. And then there were about 15,000 individuals who reported being pregnant as part of the VSafe reporting process. Next slide. So what kind of data came out of VSafe? So one of the things, just from an awareness standpoint, we know that the two vaccines that we currently have, the Moderna and the Pfizer vaccine, both have a little bit higher, it's called reactogenicity, or your body is responding more to the vaccines than you might to a typical influenza vaccine. Most folks get their influenza vaccine and they get it and they go, okay, I didn't really even know I got it, except I have less chance of getting influenza. There is another vaccine that's out on the market, the Shingrix or shingles vaccine, that many people say when they get it, they really know that they got it. Their arm hurts more. They complain of more body aches or fever, headache. They just feel fatigued and tired, sort of like they might feel if they're coming down with something. Same idea for these two vaccines, both the Moderna and the Pfizer vaccine. Most people who get vaccinated actually complain of more side effects after they're vaccinated. And the other thing to know is that they complain of more side effects after the second dose as opposed to the first. But what we know is that these side effects pale in comparison to most people's events that happen in relation to the actual virus as they have it. So generally the symptoms are short-limited, self-limiting and short-lived. They usually start in the first 1 to 2, at most 3 days after, although this graphic does go up to 7, and that's because, the 7-day period is the daily check-in by VSafe, and this is all information from VSafe. And so you can see the number of people that complained. The reason that it's just dose 1 of Pfizer and dose 2 of Pfizer, but only 1 of Moderna, is because the Moderna vaccine, we didn't actually have data on dose 2 at that point in time in January. So that info was not available because it hadn't been collected yet. But the ACIP meeting is today actually and tomorrow. And so as we continue moving forward, we should have more information about this because again, it's not a static period of time, but ongoing things. Next slide. So I said people do complain of things that, feelings afterwards where they feel like they're having symptoms or side effects. And this graphic actually just shows a little bit of how you might be able to tell the difference of if it is the COVID virus that you have or if it's a vaccine reaction. You don't get coverage from the vaccine until about 1 to 2 weeks after. It's about 10 to 14 days after you're vaccinated. You get the most effectiveness of the vaccine. We know that both the 2 vaccines, Moderna and Pfizer, that we currently have available, have anywhere between 50 and maybe as high as 85% effectiveness about 2 weeks after the first dose. But it really takes until the second dose and about 2 weeks after for you to truly get that 95% protection. The other thing I usually hear from folks is, well, if I've got 95% protection, then why do I still need to mask and socially distance and do all that hand washing stuff? Well, the answer to that is, again, if you think on the idea that they're about anywhere between 94 and 96% effective in that ballpark, you're still going to have about 1 in every 2,500 people who the vaccine is not going to work for. And we all are still working to be able to get vaccinations up to where we actually have good herd or community immunity to suppress the virus. So an important part of our process to ensure that we're thinking both safely and effectively with relation to managing the vaccine. Next slide. So this is kind of a document that it's on our website in multiple languages. And I think that the questions that I usually hear as I, kind of walk along this is a 1 page, again, it's 2 sides, but 1 pager to be able to give just general information about the vaccines and its effectiveness. It talks a little bit about what you need to do and who should get the vaccine. And I know that everyone wants to get the vaccine. We're really, well, not everyone, but most people want to get the vaccine. We're really working to try to make that as easy and as smooth as possible. And I know SheAnne is going to talk in a few minutes about the goals for the vaccine and where we are with our current allocation and processes. But I just want to keep reiterating that we are still in the world where we have limited vaccine available, and definitely the snow week before last year in Washington and then last week in other locations has slowed down our distribution of vaccine and our allocation coming to Washington. I know that we've had to cancel multiple clinics, both at the Department of Health through our resources and teams. And I know the same thing is happening with other providers. So giving us enough time to be able to catch up with that vaccine delivery, which I know is happening, but we don't want to bring people in for a clinic if we don't have the vaccine to support it. Next slide. So one of the questions that I hear a bit about is, well, what does it mean to, why would we focus on a particular population of people first? And we know that there are individuals who are at higher risk for the disease, and not just higher risk for the disease, but higher risk for complications and events that occur, including death after the disease or as part of it. So that's one of the focus pieces that we've looked at from a kind of a Department of Health standpoint, and also across the US from a leadership standpoint, to look for how we can continue to ensure that we're vaccinating the right people at the right time. Next slide. This actually shows you a little bit of information that is part of the reported info to CDC, and this came also from a recent presentation at CDC, and it shows you the risk of hospitalization and hospital death, and it significantly shows that occurring over the course of time depending on the age of the individual. Obviously, there are things besides age that contribute to the severity of disease. But we all have heard probably the information on the news where, you had a 20-year-old or a 29-year-old or a 50-year-old. And so thinking about how we're immunizing to be able to address those hospitalization numbers, but also the, reducing the number of deaths in the US is an important part of our strategy. Next slide. So some of the questions I also hear and see, and I think I've seen a couple of them pop up in the box, is, well, why do we, what are we doing about vaccine hesitancy, and why are people hesitant, or what are we doing to try to work on that process? And you can see the feelings that most people have with relation to this particular report. This is from the Kaiser Family Foundation, and looking at not only race and ethnicity, but also looking at ages of who would really like to be vaccinated and whether they're being successful in doing that or not. And then those who are very happy overall. Again, we know that we are still in that under-resourced piece from the overall vaccine supply. And so trying to ensure that we actually have sufficient vaccine to be able to immunize everybody that first needs to be immunized and then wants to be immunized. So prioritizing vaccinations with our populations that are at higher risk is really important. Next slide. So this is one more hospitalization rate information that kind of shows you a little bit more about, particular populations of individuals. And again, I think we've tried to work on and look at across Washington State by doing focus groups with different populations, having people who are leaders in that population or in that ethnic group be able to talk about what barriers there are. Sometimes it's access to vaccine, and we're trying to use equity processes to be able to do that. Sometimes it's not access to the vaccine, but individuals who are just don't want to be vaccinated. They don't have trust either in the system or in the vaccine for it to work. So that's work that we've actually continued to do and to focus on at the state level. So the other thing I wanted to talk about a little bit just for a moment is, and I saw a question pop up in the box, and because when SheAnne takes over, I actually have to drop off the group. And so I just want to answer a couple of questions. I know there have been questions about long-term care. We're continuing to do vaccinations in long-term care facilities and also with staff. We're also vaccinating part of our phase 1A population that SheAnne will talk about more is our, we're including in that healthcare workers, and it's not just the direct bedside caregivers, but also other staff who are working in hospitals and in clinical practice areas, individuals who are working in home health, trying to ensure that we are vaccinating those. Not only does that limit the disease or the virus going into, to some extent, the community or the facility, but it also helps support the residents. We do know that the vaccine has been effective to reduce, the individual from getting more seriously ill. We still are working on gathering data about how effective the vaccine is to prevent individuals from spreading. Can I become an asymptomatic carrier, i.e., I don't have any symptoms that I'm sick, but can I still expose other people after I've had the vaccine? And the answer to that is we're not absolutely sure. Wasn't included as part of the clinical trial information because we were looking at, again, we're in a pandemic and how we're doing the work to be able to support and decrease the virus and the impact of the virus. But those things are still in the process of being completely proved. And so for now, as we talked about earlier, it's so important that we continue to wear the mask, to continue to socially distance and appropriately monitor and prevent people from spreading the virus. And then also to ensure that we're doing good hand hygiene, because that really is one of the things that prevents people from spreading from one person to another. So I think I've hit everything that I was going to hit. Is SheAnne here? Are you okay if I hand off to you?
Absolutely.
Okay, I'm going to jump off the call. If there's anything that is something that I need to answer that I missed in the chat box as I push through, then I'm happy to answer questions afterwards. SheAnne will share with you a link for you to be able to get to some information. But I think if you transition to the next slide, you'll be able to get SheAnne's stuff started. Bye-bye.
Bye, Kathy. Thank you. Hi, everyone. SheAnne Allen, COVID Vaccine Director. I apologize. Kathy and I are just tag teaming the presentations today. Want to make sure that we are, getting the message out, getting the information out. And so thank you for just allowing us to pop on, be with you, and then, like Kathy, leave for another presentation. Next slide, please. So really excited to be with you guys today just to share some of the successes and some of the challenges we've had since December when we received vaccine in our state, and then also the planning and all of the the behind the scenes, the work that's gone on since the middle of summer. So first I wanted to share, we do have a goal of 45,000 doses a day being administered in our state. If we are able to achieve that goal, then that would put us at about summertime, when we would have vaccinated about 70% of the population. And that's equivalent to about 4.2 or 4.3 million people during that 7-month period. So currently we're about 27,000 doses a day being administered. So you can see still some work to do, but really 27,000 doses being administered a day is still really impressive. We have some pretty amazing partners and providers and Washingtonians, you know, in our state that are just helping us to reach that goal. Next slide, please. Wanted to highlight, we do have an external dashboard that was launched recently, and really encourage you to go check that out. There is a lot of information on there, and there's different ways to break down that information. You can look at it from a statewide perspective, from a county perspective, but please use that data. Tell us if it has everything that you think would be helpful. If we're missing something, please give us that feedback. We want to make sure that we're producing the most useful and helpful tools for the public, for our partners, for everyone. Next slide, please. So as of yesterday, we had over 1,300 providers or facilities enrolled in the program. And so these are 1,300 facilities that are across the state. We know that each facility can have 1 provider or 100 providers. You know, there's a variety of sizes. So really a lot of interested providers available to vaccinate in our state. Definitely not concerned about the number of vaccinators. Really what the barrier is the supply that we have right now in our state to be able to get the vaccine to all of the providers. Currently, each week we're only able to allocate out to about 25% of those enrolled in the program. So there's still many providers that are not receiving vaccine on a regular basis. And so really hopeful as we move forward that that will change and we are able to expand out as supply increases. You can see on the left-hand side a breakdown of the different facility types that are enrolled in the program. So really right now there's a lot of pharmacies that are enrolled, a lot of medical practice or family medicine, some public health. And then you can see on the right-hand side a breakdown of where the facilities are located in our state. There are definitely a couple of counties that have a very low numbers of providers enrolled. And so we're really focusing on getting more access points to those communities. For example, more either pharmacies, or if there is an enrolled provider, then offering mobile pop-up clinics if there are populations to serve in the current phases. Next slide, please. And just wanted to remind you who can vaccinate. I shared the link here of just who can vaccinate and what the requirements are under, for this pandemic. And so the link is there. It's a great tool. Definitely updating it as we learn more information or as there are new additions in response to the pandemic. Next slide, please. And then this is just a breakdown of the doses administered by day. The gray bars are those data that are still preliminary. And then the dips that you see there, those are typically the weekends or holidays, which we would anticipate less doses being administered. But really following a pretty steady curve of Monday through Friday, a majority of the vaccines being administered, and then dips throughout the weekend. Next slide, please. So we know that the COVID vaccine landscape is complex, and it continues to change, and it continues to change daily. So currently we have vaccine that are 2-dose series, so the Moderna and Pfizer product, and they are not interchangeable. We know that there could be a potential new candidate, vaccine candidate joining as early as next week. But we know, there's varying presentations. The vaccine efficacy or effectiveness varies between the vaccines. The adverse events could, so far they've been pretty similar among the vaccines, but for future candidates down the road in a couple of months, it could look different. The storage requirements for the vaccines are different right now. The Pfizer vaccine, it has to be shipped in the ultra low temperature units, and could require dry icing if using the thermal shipper. And so there's just a lot of logistics to keep in mind with each of the vaccines. Knowing that we still need to be socially distanced when having the vaccination clinics. So as people are lining up, waiting to get their vaccine, making sure that there is 6 feet apart, and then continuing to communicate and educate, especially as we're learning a lot about the new vaccine candidates that are coming up for approval. And then also the messaging around the vaccines as we're learning more about the safety and side effects and the programs that Kathy had mentioned, the VSafe program, and then also the VAERS reporting system. And then also we know that there's distrust in the public health system, that could be from historical experiences. And so really working with communities and building the relationships and, wanting to make sure that we are, sharing messages and getting input and collaborating on this response. Next slide, please. So I mentioned vaccine supply, it continues to be low. However, we are hopeful that we'll see some changes as we move forward in the next couple of weeks and definitely the next couple of months. Next slide, please. And then this is just a summary of vaccine allocations since week 1, so middle of December, through the beginning of February. And you can see the small increases of the vaccine over time. Next slide, please. And then recently, our CDC partners were able to start providing us a 3-week forecast. And so you can see here the small increases over the next couple of weeks. They are small, but they are definitely increases. And so we are excited about that. Looking towards the middle of March, we are receiving over 300,000 doses for that week's allocation between Pfizer and Moderna. Also knowing that this could change if Johnson & Johnson vaccine is approved on Friday. Next slide, please. So we have a lot of different ways for access to vaccine. We definitely are utilizing the traditional delivery systems such as healthcare systems like hospitals and clinics. Also pharmacies, and then as we move forward to future phases, using or partnering for workplace clinics, and then also looking and partnering with our local health jurisdiction partners for high volume vaccination sites, standing up mobile vaccination teams. Kathy is leading some mobile vaccination teams right now for long-term care and adult family homes. We'll be seeing some more community-based pop-up clinics, especially in communities that may be more disproportionately impacted by COVID vaccine. And then the use of mass vaccination, high throughput sites. We have 4 state-ran mass vaccination sites in our state. And those I think are available, the numbers are available on the next slide, but using a combination of all of these strategies to ensure that we have as many access points for all Washingtonians as we move forward through the response. Next slide, please. So this is a breakdown of the number of doses so far that each of those state-ran mass vaccination clinics has provided so far. I believe we're in week 4 of the sites being stood up. And you can see we've vaccinated over 50,000 total Washingtonians through the mass vaccination sites, or also those mobile nurse teams or mobile pods. Next slide, please. So this graphic describes the current or the phases that we have determined for the COVID-19 response. So we started out in phase 1A, and that included those high-risk healthcare workers in healthcare settings and high-risk first responders, also long-term care facility residents. And then we opened it up to tier 1A, which was all other healthcare workers in healthcare settings. And then back in January, we extended or expanded to include 1B tier 1, which was all people over the age of 65, and then all people 50 years or older in multi-generational homes. And just a reminder, so multi-generational home was where individuals from 2 or more generations, such as like an elder and a grandchild, were living. And so we had some clarification that people were requesting from that term. And so hopefully that's a little more, that information is a little more helpful. You know, we also defined it as a person who is over the age of 50, who cannot live independently and receives long-term care from a caregiver, or someone, or lives a person who's over 50 who lives with someone who works outside the home, and then also a person over the age of 50 who lives with a younger child, such as a grandchild or a niece or nephew. And then what's not eligible for that is someone younger than 50, someone who's 50 who cares for their partner or a friend, or someone who, or any parent or a guardian who cares for their own small children. And then we know that we'll be moving forward to phase 1B, tier 2 and beyond soon. And, you know, that could be in March or in spring sometime. There are conversations taking place, and we'll definitely be sending out messaging well in advance so that people can prepare for that transition. Definitely had some lessons learned from when we transitioned from 1A to 1B tier 1. Next slide, please. So the guiding principles through the development of those phases really is to think about the highest risk or who's at highest risk for exposure, to maintain the medical and surgical surge capacity, to protect the most vulnerable, and to reduce hospitalizations, severe morbidity, and mortality. Next slide, please. And then really making sure that equity was a piece of all the decisions, and it was a piece of all areas of the vaccine response. Really focusing on people with access barriers to healthcare, people at highest risk for exposure, people essential to health and well-being of populations at higher risk, people who live in areas with greater spread, people who have been disproportionately impacted by COVID-19 because of inequities, people at risk for severe illness, and people who are at higher risk for spreading COVID-19 to high-risk populations. Next slide, please. And so back in October, we spent the entire month really focusing on engagement. And so that month we did virtual meetings, we held town halls, we posted a survey on our website and received over 18,000 responses. All of this information was collected, and really it was used to determine the phases that I mentioned a few slides ago. It was the feedback that we received, you know, really was used to help with that prioritization and really helped clarify and guide some of those pieces. For example, including the multi-generational piece for 1B1 is something that I think our state is the only one that is doing, and that's because of the feedback that we received in October. I don't think other states have that as one of the early priority groups. And then I mentioned the broad engagement, so that was the web-based survey that received over 18,000 responses, and then stakeholder engagement, lots of presentations to coalitions and community members and different partners throughout the state. Next slide, please. And so this was just a summary of the engagement. mentioned 90 total key informant interviews, and then 568 total individuals from those key informant interviews, and really just, again, trying to get as much information from as many different people in Washington to help guide that process. Next slide, please. And you can see here the breakdown of the web-based survey I mentioned and the different survey formats that we had available online. Next slide, please. And then this is a breakdown of all the counties that participated in the engagement efforts. You can see the ones with asterisks. Those are the ones that had more focused engagement. And so really well represented Washington in general as a whole. Next slide, please. And so I mentioned that we are, focusing on equity. We recently released a report, and in that report, there are gaps. There are gaps and inequities in our current vaccine distribution. And so moving forward, we're figuring out ways to decrease those gaps. And so really using the social vulnerability index as a tool to help direct where vaccine should be allocated, making sure that it's going to those populations that are most disproportionately impacted, or those populations that are serving eligible people that are eligible for the current phase that we're in. Next slide, please. And so other ways that we're ensuring equity across our state are, I mentioned using the SVI tools. Also, as we have appointments available for either mass vaccination clinics or these pop-up clinics, making sure that there is availability for call-in appointments, not only online, knowing that maybe someone might not have access to the internet or would prefer to call someone to help make that appointment. So really thinking about different ways for scheduling appointments. Also providing materials that are translated and culturally relevant that are available on site, setting up interpretive services, and then really being explicit in statements that the vaccine is for everyone, including immigrants and any person living or working in Washington, regardless of their immigration status. Next slide, please. And so this is just an example of a screenshot of the Washington COVID-19 Social Vulnerability Index that I mentioned as one of the tools that we're using. Next slide, please. And I mentioned equity, really using that as a guiding tool for decision-making, really looking at Black, Indigenous, and people of color communities, people with limited English proficiency, people in shared housing, crowded housing, and multi-generational homes, people in poverty and low-wage earners, people with disabilities, and people with access barriers to healthcare. Next slide, please. And again, I just wanted to point where the guidance is for the phases. It is updated as we move forward through the different phases. It is a great tool that really, I think, lays out where the decisions have been made and then where there's still opportunity for conversations moving forward as we're moving to future phases. Next slide, please. I mentioned the recent report, the race and ethnicity and age report. There is the website for it. And then if you go to the COVID-19 data dashboard, in the middle of there's the reports, and you can click on that race and ethnicity and age report there. Next slide, please. So I mentioned and I know Kathy had this slide as well. So we currently have the two vaccines, the Pfizer and Moderna 2-dose series, separated. Pfizer's 21 days apart, Moderna's 28 days apart. On Friday, the Johnson & Johnson vaccine will be going under review by the FDA, their VRBPAC committee. And if approved, then the CDC's Advisory Committee on Immunization Practices will meet on Sunday and Monday to make their recommendations for who should receive the Johnson & Johnson vaccine. So these are two routine procedures that take place for any vaccine that comes to market. So first the FDA will approve or not approve, and then the CDC will make the recommendations for who, based off of the clinical trial data, who should be receiving that vaccine. And then we've heard from our partners that if approved, we could be receiving that vaccine as early as next week. So the Johnson & Johnson vaccine anticipates, if approved, to be able to ship 2 to 3 million doses next week across the nation. And so since Washington's about 2% of the population, we would expect to receive about 40,000 doses in our state. And so really just, again, an exciting time to see supply increasing and a lot more opportunity for people to get vaccinated. Next slide, please. Also, Johnson & Johnson, I'm sure that Kathy reviewed this, but a little bit easier logistically. It is one dose. And then the storage and handling piece for it is a little bit easier. It doesn't have that ultra low temperature requirement, and it's more of a freezer, can be stored longer in the refrigerator. Sorry. Next slide, please.
Oh, SheAnne, this is Heather Erb. I hope you don't mind me interrupting you. I just wanted to let you know we're at our time where we're going to start our questions and answers. I didn't know if you had any just a final item you wanted to mention before we start into our question and answers.
I think there's just two more pieces that I do want to highlight. If I could have 2 more minutes.
Absolutely.
So this is just a projection I had mentioned. By middle of summer, we would anticipate going through phase 4 of the vaccine response. Thought it was helpful over on the left-hand side to show the population estimates for each phase, just so people can see how big those phases are and anticipate based off of the number of doses we receive in our state, how long we'd be in each phase. Next slide, please. And then next slide. Wanted to get to next slide. Sorry, I know we're limited on time. Wanted to mention the vaccine finder or find your phase tool. So this was updated over the weekend based on feedback that we received from public partners. This is an online tool. However, we have included a paper form, and then also if a person would like assistance navigating this, this tool, they can call the 211 number for assistance with that as well. Also, it is available now in 39 different languages. So again, just another tool that we're trying to make it easier for all Washingtonians. And I think that was the main slide I wanted to get to, just because that information was just released. And actually, if you could go forward 4 more slides, I just wanted to talk about the collaborative, which is there we go. It is it's a group of individuals. There's about 50 individuals, and it's an opportunity for people to come together, discuss different topics, and it's led by the collaborative and provide information and to Department of Health and to all of our partners about various topics throughout the year. They've met twice so far and really had some rich conversations, mentioning, there was over 300 people in attendance each time. In the future, when we have different topics, we will be breaking out into different work groups so we can have more intimate conversations, but really encourage you to join if you're interested in that outreach effort. And the information's on the slides. Okay, I am done, Heather.
Okay, thanks, SheAnne. So we've collected questions, quite a few questions, not just today in the chat box, but also through email in the last week. So I'm going to start off with a few of those questions. A lot of the questions we've been getting in the emails, and then we'll get to the chat. I think the number one question that we're getting are from folks that are concerned that Whatcom County has not received its proportionate share of vaccine compared to other counties. And because of the vaccine shortage in Whatcom County, many residents are driving as far as Skagit, Snohomish, and King counties for their first dose of vaccine. And often there's no assurance that they're going to get their second vaccine from those providers. How is the state addressing this issue of ensuring individuals receive their second dose and that Whatcom County is receiving the appropriate share of vaccine?
Yes, absolutely. So we have been sharing out with all enrolled providers through multiple different venues that for every first dose, there is a matching second dose that they have to place it in the system, but that we will guarantee it. So we, if a provider, and we're encouraging people to go back to where they received the vaccine, and then also for providers to make sure that there's appointments scheduled before people leave their appointments. I know that each of the systems and providers have their own process in place, and I know that that was not happening early on. And so that messaging is now being provided and as an expectation of providers. And so if if someone leaves an appointment and doesn't have information for how to make that second appointment, then please, reach out to them and make sure that that's scheduled before leaving. Also, so for Whatcom County distribution, so I know that the first, I would say, 10 weeks of vaccine distribution, it's been clunky and it hasn't been perfect. There's been a lot of different injects along the way, and it's changed over time. So for example, the first, so let me back up. Also, we had 2 vaccines that have 2 completely different minimum dose ordering. So Moderna, you can order a minimum dose of 100. Pfizer is a minimum dose, used to be 975. Now with the 6 dose per vial update, it's 1,170. So a big variation. So even if I say we're to, provide vaccine to one provider that can accept Pfizer because of those, logistical barriers, and then I can't divide up their order. They're going to get that 975 is the number we were using before, which is a lot more than the Moderna one. So I can't separate that one out. And so that's one challenge that we were looking at. Also, the first couple of weeks, we were looking at pro rata based on healthcare workers per county. And so that was something that wasn't communicated out, and that definitely had an impact on how many doses were going to each county. And then as we moved to 1B1, we were using pro rata based on elders in the community. And again, that changes the pro rata and just the expectation of how many doses were going. But now we're doing overall population as we're moving, expanding through the phases. That makes the most sense. We also there's lots of criteria that go into the allocation. So then it also looks at if a provider is administering the vaccine within the 7 days of receipt. Also looking at if the provider places the order in the immunization information system and if they're reporting the information. That was a big struggle for those first couple of weeks. They weren't providers. It was a new process and it's not an easy process. And so we were having reporting issues. Also looking at equity and if there's equity, if there's plans in place, if there's open points of distribution. So lots of different factors that are being used to determine where vaccines going in Washington.
Thanks,
However, moving forward, now that we have the 3-week forecast from our CDC partners and we're sharing that out, we are working on a plan to be able to share out to our local health jurisdictions a 3-week planning process as well, where we'll be able to say, okay, Whatcom County, your population for the state is, X number. And so you would expect to see for this week, week 14, you would expect to see, I'll just say 10,000 doses. And then week 15, you would expect to see 10,000 doses. Oh, but we have an increase in week 16, you would expect to see 11,000 doses. And then that way our local health jurisdictions, I mean, we know at the state level that our local health jurisdictions have a way better sense of what's going on in their communities, who's partnering, who's has high throughputs, where there's linkages to different communities. And so we can work with our local health jurisdictions to say, for them to say, you know what, give to this pharmacy, this federally qualified health center, this hospital, this provider, you know, and so on. And so hopefully moving forward, it's going to make it a lot easier for all of our partners, all of our community members and Department of Health.
Thanks, SheAnne. Okay, so our next, I think the second most common question that we're getting is about accessing the state's navigation system for getting an appointment or other navigation systems, technology, essentially. Even folks who are very technologically savvy are spending hours and hours a day trying to secure an appointment online. Can you talk about some of the changes that we're going to see coming in the future to make that easier for folks?
Yes, absolutely. So we are working closely with, with Microsoft too, and other, large businesses or private businesses in the state to assist with hopefully an online scheduling, like a one place where people can go to schedule appointments that would then link into all of the other scheduling tools that enrolled providers are using. And in the meantime, while we're trying to build that out, we are trying to improve that vaccine locator page that I had mentioned right before I ended the presentation, having an interactive map that will show like, okay, this provider, this is real-time data, this provider has vaccine. And also if they have vaccine, this is what type it is, so that people know, okay, I received Moderna for my first dose, I need Moderna for my second dose. But so trying to have that as real time as possible, so that people, reducing the frustration for being able to make those appointments. I know it's been frustrating that limited supply is the biggest barrier, and that's why we're not seeing that many appointments open, which is causing a lot of the frustration.
Thank you. Another question we've been getting a lot of, states across the country have different strategies for getting the vaccine out, whether it's emphasizing max vaccination sites, pharmacies, etc. In Washington state, the initial plan really started with getting vaccines out through healthcare providers primarily, and a little bit through pharmacies. With all that's going on now with the federal retail pharmacy program, where vaccines are going to go directly from the federal government down to the pharmacies, increases in mass vaccination sites, how do you see, if at all, the role of healthcare providers changing as they're dispensing vaccines? And could that possibly divert vaccines going to some of those organizations that you talked about to get to make sure we're reducing racial inequalities?
Yeah, absolutely. So I had mentioned it on the previous slides about having a variety of different access points. So I think it's going to take all of those different methods for us to be successful. We know from feedback that one person might feel more comfortable going to a pop-up clinic in their community, whereas I might be okay just going to a pharmacy or going to my local provider, but knowing that one method's not going to work for everyone. And so having a variety available, each of them are important to the success of the response. And so I think especially as we receive more vaccine, we'll be able to allocate more out to the individual providers or the large hospital systems again.
Okay, thank you. On February 16th, President Joe Biden in a CNN town hall stated that every American who wants a corona vaccine should be able to get one by the end of July. And this is the college community, and many are wondering, will students and staff be able to go back to in-person learning in the fall? What do you think the likelihood is for delivering on this promise nationwide and in our state?
Yeah, I mean, I think based off our projections, you saw the slide there, we still are, and especially if we can increase that goal to 45,000 doses administered per day, I think that we can make that summertime goal. Especially we have the methods in place to have high throughput. And so if we can get vaccine to all of those individuals, I definitely think that we can get there and hit those goals. You know, last week was, you know, kind of put us behind because of weather impacts on the East Coast or the Midwest, where we then received no vaccine in our state. But I think that we'll see a lot of enrolled providers really standing up and having a lot of high throughput clinics this week and over the weekend to get caught up.
Okay, thank you, SheAnne. I see still so many questions popping up in our chat box. I'm going to turn it over to Christine Perkins to take some of those questions. Thank you.
Yes, thank you. One question is regarding why not health providers are providing waiting lists. That would be helpful to people and would keep them from having to check multiple websites multiple times during the day, since they don't know when the providers will list that they have vaccine available. Has that been something that the state has considered facilitating?
Yes, it is definitely something that are having conversations about. I think first we're, you know, trying to make the online scheduling system easier. Also trying to open up different varieties of ways for access to those appointments. But yes, the wait list topic has come up, and we're trying to figure out the best way to try to implement that.
And how about options for folks who aren't computer literate going forward?
And I mentioned that in the presentation where we're reserving, you know, we did the pilot for the 4 MassVac sites where we're reserving a portion of the appointments for phone call only instead of the, reserving by online, knowing that one, people might not have access to the internet, or when placing an reserving an appointment online, it's a race. You know, they're posted and they are filled up quickly. And so having a variety of different ways to secure appointments is definitely a goal as we move forward. But yes, we are trying the call-in option and definitely open to suggestions for other ways around to remove these kind of barriers.
Got it. So it appears that there's an honor system involved. People know of other people who have claimed that they live in a multi-generational home in order to qualify for the vaccine. Is the honor system working right now for people?
I mean, I think it is. I think that it's built on trust. We built the guidance based on those at most vulnerable, those at highest risk. And so we hope that people are understanding that that there's a reason for the guidance and the reason why people may or may not be eligible right now. And so hopefully they'll take that in consideration and assist those that are actually a vulnerable individual or a high priority person and assist them to get the vaccine instead of taking the place of that person.
Okay. And another angle here, if restarting schools and higher education institutions of higher ed is a statewide and national priority, why aren't higher ed faculty and staff on the priority list for vaccines?
So teachers and staff of schools, they are on, I mean, they're on the priority or high priority list. I think we'll see them included in the future phases. Still lots of discussion for anything after 1B1.
Okay, got it.
And this is Hannah. Could I jump in real quick?
Yes, please.
Thanks, SheAnne. Sorry, this is Hannah Feedback. I'm a policy advisor on SheAnne's team, and I just wanted to clarify the reasoning behind the way that we've done our first eligibility groups, and we touched on this a little bit in our presentations, but with such limited supply, we really have to kind of target who gets vaccine first and the reasoning behind who's currently eligible. So there was healthcare workers at first, and our long-term care and our high-risk first responders, because we really want to protect those healthcare resources, because in the midst of a pandemic, those were seriously overburdened. And so those were the first groups that were eligible. And then right now, as SheAnne said, the next groups that are eligible are anyone in that first phase that I just said, plus those over 65, as well as those who are 50 and older who live in multi-generational households. And the reasoning behind this next group is we are really trying to, like I said, protect the healthcare system, because this group that's now eligible, they're more at risk for severe COVID. They're more at risk for complications, and even at higher risk for potential death. And so now that we've kind of working to strengthen our healthcare system, we're working to address those first populations that are really using those healthcare resources. And so then once we get through that group, we're looking to, again, the next phase, which would be looking at our state's essential workers, and those are, of course, our teachers and staff who support schools.
Thanks, Hannah.
So you mentioned that, we're still not having enough doses to vaccinate all the eligible people in the current tier that we're in. Why would we consider moving to another tier?
We're planning for future tiers. We don't have a date set for when we will move, but definitely lots of planning has to take place, at Department of Health and in partnership with all of the partners across the state. Definitely, there's just conversations, and we want to make sure that we are ready for when it is actually time to open up to include more eligible people.
Great. You talked about the distribution of vaccine within Washington State. Do you believe that Washington State is receiving its fair share of vaccine compared to other states?
I do. The CDC is distributing it on a pro rata population-based method. And so for each, for the amount that they are sharing, that they have each week nationally, we do our quick calculation of 2%, and that's typically in line with what we receive. So thinking that based off the numbers that we're hearing nationally, yes, I feel like we're receiving our fair share based off population pro rata.
Okay. You earlier mentioned the mass vaccination sites in Washington State, and I'm curious about why there are none in Western Washington.
Those sites, and Hannah, please feel free to jump in if you have additional information. Those sites were, they were determined based on social vulnerability. There was lots of criteria that went into it, but social vulnerability, looking at where other county high throughput sites maybe already stood up, looking at facilities that could hold a mass vaccination site across our state. Moving forward, we'll definitely be evaluating if there's better places for the sites to be held in partnership with local health jurisdictions. And definitely open to feedback about where you think a better site would be located in our state to stand up.
And SheAnne, I would just add to that. I think that was great. The mass vac sites SheAnne mentioned, those are the 4 state-led, state-supported mass vac sites. So those are in addition to any mass vac sites that maybe a local health jurisdiction is standing up. And I would explain just briefly the Puget Sound area in terms of where on that map SheAnne had of the enrolled providers. The Puget Sound area has the highest concentration of enrolled providers. There's just a large population of folks in that area. There's a lot of healthcare providers in that area. And so we're trying to be really intentional in our efforts about getting vaccine out to different areas of the state. And so I think that was part of the reasoning behind where those 4 state-run mass vax sites are. And then I know a lot of locals, of course, are working in addition to open up their own mass vax sites too. So we're just trying, different ways of getting vaccine out across the state.
Great. In addition to the new Johnson & Johnson vaccine, are there any other one-dose vaccines on the horizon?
The Johnson & Johnson is the only one that we were, as a program, tracking currently. I think that there are other ones that might be, in phase 1, 2, or 3, but really we were watching the Johnson & Johnson and AstraZeneca one closely the last couple of months.
Got it. There's just a comment about some of the programming errors that have been perceived in terms of appointments and such. Provider in Island County doesn't have a way to cancel an appointment, etc. So just, I guess that's more of a comment than a question, just mentioning that there's some issues with the scheduling processes with various providers.
Yeah, definitely hearing it, the frustration and trying to figure out how to make it easier as we move forward is definitely a priority.
Right. And I guess when the eligibility is opened up to essential workers, question about how that might be organized. Working people don't have the same time to check websites daily and hourly the way some of the older, maybe retired folks have been doing it.
Mm-hmm. And that's one piece of the equity piece that we're trying to incorporate as we move forward. Also, like I mentioned, we know that this next tier it's a large population and we still have very limited doses. And so really trying to, avoid what we learned when we moved from 1A to 1B1, because that was another perfect example of a large population and just a lot of frustration around our state. And so thinking about ways that we can avoid that.
Okay, someone's asking about vaccines for children. The understanding is that there isn't currently one approved for kids. Do you expect that there would be one? And if so, when would it be available?
I think there are clinical trials going on. We have one vaccine that's approved down to the age of 16, and then the other 2 will be 18 and up. But definitely clinical trials going on. We should have more information, I would think, later on this year. But I'm not sure of the exact age indication that they'll be required for. What I'm hearing is 12 and up. So either 12 and up or it could be the 16 and up. We'll find out more as it gets closer to being reviewed by the review panels.
Okay, I see that we have time for about one more question. And Susan has asked, why are some local public health departments involved more in vaccination than others around the state?
So I think that, we would love all local health jurisdictions to be involved in the process. We have different platforms that we communicate with local health jurisdictions on throughout the week, and then on weekly meetings. I think that the capacity for each local health jurisdiction is different. Whether how many staff they have dedicated towards the response section or portion of the response. We know that people are stretched really thin. And so some counties are able to communicate with their providers or the federally qualified health systems or the hospitals more frequently, and then some may not. Some help with planning, some may not, but really wanting Department of Health to be available as a resource for those that might not be able to have as many staff, dedicated to the vaccine portion.
Okay, well, I think that was the last of our questions. I just want to thank SheAnne and Hannah and Kathy. I know she had to leave. These were a lot of tough questions. I know that you guys have had to answer a lot of tough questions for over a year and that you have been working around the clock 24/7. So we thank you for your public service and for your time and being here today. And we thank also our audience members for all of their great questions today and that they've sent to us in advance. So thank you.